from Mount Sinai Cath Lab, and to all our panelists, and of course I'll use up everybody's name slowly, but we just wanted to make sure from start point of view, can you hear us and see us well?
Yes, sir. We hear you and loud and clear, and we can see you very clearly.
Beautiful. All right, Dr. Jay Shah, you are my co-moderator today for this case, our Learn from the Master series, and many of our friends are on the line today as a panelist, and more importantly, we welcome Dr. Akiko Mehra, because today will be a lot of discussion on the IVUS and also on the IVUS aid, which actually have the app just released and became very popular. So with that note, welcome, and let's start our presentation so we get to the case here. This is our episode number 8, Learn from the Master. We'll talk about application of high definition IVUS in complex PCI and IVUS aid, support from Boston Scientific, India, ESCC, and of course Mount Sinai Hospital, New York. So the case wise, this patient not moving. So guys, it is not moving because, next slide. Okay, good. So we are two of us, no disclosures. And so looks like there is no battery in this remote control or what? Okay, this is the case number 8, a live case of, and then we have the next one in July. And so 76-year-old female has a CABG and now presented with new onset angina with positive stress test with multivessel disease. And you can see there the CAD risk factor, besides that had a PAD, and actually CABG was just done in June of 21, just a little less than 2 years ago with a LIMA-RIMA Y, and then had a stress test recently, which has positive, also has a failed ablation, a good medical therapy, and patient is on LIMA-RIMA also. So key is the Cath was done a few days ago, and they will show the angiogram. Anu, you want to show the angiogram? Basically, the graft was good, but lot of jeopardized vessel with a normal ejection fraction, and that's what our part of will be the revascularization. So let's show it from angiogram point of view.
So we have the EF about 40%, right?
No, they actually said 50 plus, yeah,
50.
50 plus, yeah, okay.
And we are taking the native later. I just wanted to show you the native picture. There's a LIMA that's filling the LAD. There's a large diag that was not bypassed. So you have significant left main disease. You can disease in the ostial circ, ostial LAD, and then there is a moderate size OM that was not bypassed. OM2 has been bypassed. Yeah, this is where we are. And let me show you the RCA is total, and RCA fills from the left side. So this is the LIMA-RIMA Y that's filling the LAD, the OM2, and as well as the RCA.
And apparently they found the RCA very diffusely diseased, so surgeons did not bypass the RCA. So let's go to the, and patient also had a Watchman device, and we put a temporary pacemaker because just after Cath last week, patient developed heart block. So probably what needed, but we thought we should just do. So let's concentrate on what we are going to do. From the, this is a protected left main. We show the angiogram. So let's talk about the plan in this particular case, and then we'll ask our panelists that how we do. Patient is still ischemic. Now question is, patient just have a CABG 2 years ago. Well, this is a case of incomplete surgical revascularization. And I'll take the opinion that after patient did have a stress test negative within 1 year, but then this stress test recently became positive, both inferior and lateral ischemia. Actually, it was apical and lateral, so not inferior. And turns out to be this right gets the collateral, and there was nothing not inferior radded. But there is a distal left main, a 111, and then concentrate on the LAD diagonal. So I think lateral, to me, the diagonal should have been bypassed. I mean, look at this, good size diagonal. And the disease was there. Before the bypass also was not bypassed. And the circumflex will clearly have that RIMA Y, but probably not enough to supply the blood flow. So this is where we are for this patient, and very calcific disease. So Anu, tell us your plan so that we go through what we need to do here.
So we'll just rota from left main to LAD. And I think circ we should be able to take care just with balloon.
Yeah.
Ostial. Maybe cutting balloon to the circ. Now, do we plan to take care with the diagonal with the stent?
Yes, yes. I think diagonal has to be. If you think about most important vessel in this case, which we are revascularizing, jeopardize, is the diagonal, because circumflex. Remember that goes to OM2, fills rest of the circumflex, and to me, I think the symptoms the patient really had from the diagonal, and diagonal is a good size diagonal, 2.75 millimeter, and so. And the question then comes, although calcified, all the post-CABG cases are all calcified, we all know. And of course, we can take opinion. We got the real IVUS guru or IVUS expert with Akiko Mehra in terms of this calcium. I mean, whether you need the imaging to answer that, is it calcium or not? But angiographically, clearly, distal left main proximal LAD is very calcified. So any comments from, yeah. Let's discuss the case now, and how everybody else will treat this case differently. And knowing that the ischemia was a significant ischemia in the lateral wall, that we definitely need to take care of that diagonal. Yes. All right, Jay or Sanjeev,
After bypass.
opinion, and then imaging point of view that from Akiko, that imaging now or after some plaque modification. So, I mean, I'm sure a lot of people may do the imaging to decide what degree of calcium, but we actually have been teaching and doing that, teaching and preaching, that once you see this kind of a tramp track calcium modified with your technique, whether atherectomy, orbital, whichever way you want to do, maybe some cases just IVL, and then followed by imaging to understand that is that enough, or you want to use combine it with the additional device synergy. Okay, guys.
So-
Take care.
15175.
Dr. Samin,
One
Ankush here.
Yes, Ankush.
So, sir, it's a fantastic case. Angiographically, it's looking a heavily calcified vessel. So it needs to be modified before putting the stent. So one question from my side, in fact, I will ask the panel, what's your opinion regarding use of OCT over IVUS for a calcified vessel, number one. Number two, recently we have just read the paper, the fantastic paper by Akiko that has shown that even with the IVUS also, we can, quantify a bit of calcium. What's your opinion?
Yeah, so I think, let's hear from Akiko then. Yeah.
Now, before that, let's decide.
Yes.
What is, we are going to do rotational atherectomy, so what should be the burst size? So if we decide that we are going to get into the mid-LAD, where it's aneurysmal, then we have to go
1.75 is good.
into the aneurysm.
Yeah, just up to there. Yeah. So burst size, we decided 1.75.
Definitely we need 175 for
Yeah.
the left main.
Yeah, so clearly there is a short lesion before that diagonal. And the question is disease, as you see, the guide, they should show the hemodynamic tracing also at the bottom, because once the guide engages, there is a significant dampening. So question always comes once you decide about the OCT, ostial always is a trouble. And for the left main, I know, and of course, let's hear from, we know the quantification of the calcium can be done on IVUS also, besides just the OCT. But more importantly, the left main assessment, not in this case, because this case we know a patient had a left main disease before, now maybe a little more progress ostial, which is causing little ventricularization of the catheter, that moderate left main disease is there. Which technique would be better? I think answer should be, and that's what we want to hear from Akiko. One, left main, IVUS or OCT. Second, non-left main, IVUS or OCT with a thinking that it's the normal creatinine. So Akiko, enlighten us now.
Okay. Answer for one, IVUS. Answer for two, either. And I think why we need IVUS for this particular case is, as you said, that's damping, as well as the left main vessel diameter is smaller compared to the LAD. So obviously this is diffuse disease, so it has to stand up to the ostium. If so, we really have to check the ostium coverage as well as the neural deformation, etc. So I think that for this, IVUS has to be. Number two, if this is non-left main as well as creatinine is okay,
3O50,
I think we can
3.5.
see the thickness of the
3O.
calcium.
3O,
So
3.50.
probably OCT is preferred, but
Then
I think
20,
either
20,
one
20.
for non-left main, I think it's preferred for the operator.
Okay.
So this is Jay.
Yes.
Sir, by any chance, can we see the pre-bypass angiograph?
You know what? We should be able to get that. Right? We have
Yeah,
that.
okay, sir.
Yeah. Yeah. Let me taste it because it was done outside, but it should be in our system there. So give me a little time and we'll show that. Yes. Okay. Now
Sure, sir.
ready to do the IVUS.
Yeah.
Do the rota and IVUS we plan. But the bar is already there. He's a 1.75 has been selected.
You did not ask the question to the panel, how many people would have done IVUS before versus what we say that in tram track calcium that you angiographically see that we would not do any imaging before, but only after we done some kind of, plaque modification. So we have picked 175 bar. We are in the left main. Now we see that we have seen that there is damping as soon as the guide is engaged. So the guide is outside. So I'm going to start burring right from the ostium. So we do our 3 steps, which is our knob, move backward, forward. That is taking the tension from the Teflon sheet and the burr. Y connector, move backward, forward. Any tension between the burr and the wire. And the last, on the dyna, we will just do a tap. Good. That's about it. Going okay. So we're going to start the burring now, right there. Okay.
এসো শুনুন এখানে চেয়ারটা দিই
Patient developing bradycardia. Yeah. So when he says 20, I will stop. So here I think very important one point was you see the mid LAD with aneurysmal just at one spot. I think that's one place where you have to be very careful when we are doing the burr. Either we stop before that, or if we are entering into the aneurysm, just be very cautious. So now we will do the second run. There's not a lot of disease after that in the prox LAD. Good. Any questions on the burring technique now? So just doing a polishing run all the way.
Annapurna, I am Dr. Kahali here. I have a question that
Yes.
instead of 1.5, why you took 1.75? Because the LAD distal to the diagonal looks to be a very narrow artery. Don't you think that 1.5 would be a better selection? Of course, you are
our
master.
goal, yeah. So our goal was, you see here, just to take care of the LAD before that aneurysm, and then we have plan is we'll wire into the diag and take care of the diag. Now mid to distal LAD, which is significant, we are not going to do anything because the LIMA is already supplying that area. That's the reason. And if you are taking care of the left main, it's a large left main, 3.5 to 3.75 left main.
Left main,
For the left main, you needed that. That's the reason we went with
And
1.75.
I completely agree with your plan that in such a lesion where the calcium is very much evident, I think we should go for the imaging later on, and IVUS is the best for left main imaging, I think.
Another
I think going
point
back to the question, I
short-
think somebody had asked whether it was IVUS or OCT. Distal left main, you can still do OCT if you are interested, but if you want, up to the ostium, like here, we know when we are going to stent, we are going to come up to the ostium. I think IVUS is a better choice in this situation. For non-left main, I think it's up to the operator what they are comfortable with and what's the imaging. I mean, like we always teach, you always try to do one technique and master that technique. So if you think you want imaging with IVUS, and then learn the IVUS very well. Otherwise,
Nice.
if you feel comfortable with OCT, try to do OCT. The only issue with OCT is same. You want to make sure the patient's creatinine is okay. You can't do it in small vessels. You can't do it in very large vessels.
And I think
So,
the man, that
and-
was a very good point of that using 1.5 versus 1.75. I'm telling everyone now that don't be timid in this day and age saying that you are using a small burr. We all know a smaller burr will cause less problem, less complication, although it may require in a heavily calcific some adjunct. And knowing that now you have IVL or cutting balloon, in many of these cases, after using a small burr, that is perfectly fine. So that is what we want to do. So question was, we actually, we had this discussion that do we use 1.5 or 1.75? We thought that if for left main, which is the most important calcium, see that the most calcium is in the left main,
No.
not in that LAD. It's a
Or
really
you want
left
IVUS?
main.
You want IVUS now or be balloon?
Yeah,
Dr.
we have to balloon then
Dr.
IVUS.
Sharma?
Yes.
Dr. Sharma, this is Dr. Sugi here. I just wanted to
Yeah.
know why you thought of burring into the LED and not via the left vein LED diagonal, which is your primary target, so that you can you can burr the ostium of the diagonal also and the other.
Oh,
It'll be
yeah.
easier for you to take devices there.
Right. Now,
Okay.
Yeah, that's a very good point. Let's show it.
That step is an absolute no-no.
See this now?
That you are going from
Yeah.
that aneurysm into that DAG. That's a no-no. Even we would not do it.
Yeah. So key is,
And,
that's
just,
a point that's a very important point, that if our goal was to do the diagonal also rotational atherectomy, which is if it is a straightforward segment, this angulated, this is the diagonal which will perforate. Chances of perforation with the rota is about 1.2, but this kind of diagonal will be at least 8 to 10. Just happened last week in our Cath lab. They tried to do a diagonal, this kind of diagonal, and of course had a perforation with the rotational atherectomy. So what we learned in this day and age, that keep rota or orbital, actually statement goes for both, rota and orbital, away from this rotational, from the angulated diagonals, because majority of that perforations occurs in these diagonals. Now, sometimes if there's no other choice, of course, now we have a good choice. Some of these cases you can just do the IVL if you can advance, or do a cutting balloon. So this, because of that, we we kept the LED, and idea is just going to do up to the proximal part of the LED into the diagonal, and of course the left main, and avoid this kind of angulated diagonal for atherectomy. So I mean, that's what I would say. Now, which case would you do it? We try to do a balloon, nothing goes in, IVL doesn't go, then maybe we change everything and use a 1.25. If I had to do a atherectomy of this angulated diagonal, I will use a 1.25 bar. Sanjeev, what do you think? What's your opinion on this point?
This was. Is this a 3O balloon or a smaller?
It's a
balloon?
3O. No, it's a
It's a
3O.
3O balloon. Yeah.
It's a 3O. Went to the diagonal? No.
No, it's that's not 3O25.
Yeah, but dial it. No, it's okay. 2.5, okay. Yeah, 2.5, we are fine. Yes, as you see also, we are leaving the rota wire there, just using a one single blade, like a score flex type of cutting balloon situation. And then we are going to do IVUS after we open the diagonal. Yes. There was a question.
So a little more discussion about the diagonal modification, and I can see that in the mid lesion of the diagonal which you're going to stent, there is still calcium there, and you will need some strategy there also. Of course, we have not imaged it till now, but then you'll need some strategy there. So what is the strategy for the diagonal? Would you image it first and then
very
decide,
good
or?
points. So I would, if my strategy there would be, we are just going to go with the high pressure balloon dilatation. If it does not yield, then first my device will be cutting balloon. If the device cutting balloon does not do, then I'll use a 2.5 IVL.
Dr.
And this is not that circular, this is not that circular calcium which will not yield. So this is a calcium, but it will be a moderate. It's not a severe calcium, it's a moderate calcium, as you can see here, that yes, we may need, it may respond to high pressure. We actually went 2 years ago, we did a live relay to TCT with the diagonal, very calcified. We did the LAD, then we used a 1.25 for the diagonal. It never crossed completely, only half rotablation done for the diagonal. In those cases, I think is right thing. Don't go all the way, will create more trouble, and then we subsequently dilate it with the balloon. So this is a 2.5 what,
No, I'm
15?
going in the middle.
Huh?
2.5, 15. Yeah. got
15 non-compliant balloon, and we see it opens up. If not, then first thing I would do here is the cutting balloon, Wolverine, and if not, it doesn't yield it, then we go with the IVL. But here looks like reasonable. May
Yeah,
not be
it is
perfect, but
yielding,
we'll
yes.
see. Yeah.
Yeah, it is
Samir sir,
yielding.
what is your
But
opinion
at
regarding
this point in
opening,
time, I think
Mhm.
if you
Yes,
can just image this vessel.
we do. Yeah,
Yeah.
we'll go. That's our plan. Absolutely, yes.
Samir sir, what is your opinion regarding the opening up of the tight left main and tight, that LAD lesion just before the diagonal? And do you think that it may result in a competitive flow in the distal LAD that is already been bypassed?
Beautiful. And I'll tell you there, besides that, there is a 90% lesion in the mid LAD after 2 septals. But yes, you are right. If you do completely revascularize, you may be in trouble for the competitive flow. We have seen those cases, but this case we knew, and we tried to get hold of that film. Actually, they were not able to upload on that day. I remember now, and so I cannot show the old one. But see that there's very tight lesion in the mid LAD, so we are protected from that point of view. And now the balloon, I think it has opened, and we can remove the rotawire now. We don't need the rotawire, and we are going to do the imaging for everyone. So let's guess. I always like the prediction model. The prediction model will be the IVUS point of view, the high score 4, 5, 3+. For the left main and proximal LAD, and diagonal will be 1, or means circle will be.
So I was a die.
D2, yeah,
Small
yeah,
vessel.
yeah. Will be less than just about 90-degree arc of calcium. So but that's what based on the angiogram. We did the trial, particularly the MACE, and we asked the interventionalist actually. Jeffrey Popma was the core lab and was 450 patients trial, and we asked the interventionalist tell us
Take it out.
based on the angiogram, how would you grade that to mild, moderate, or severe? And the strategy was whatever they needed to do. And very interesting, we as an interventionalist are very good in measuring or I would say predicting or for the severe calcium. It was 98.6% concordance. Once you got to the moderate calcification, it was 92%.
Yeah, I see that.
If in the mild,
Go up.
in the mild calcium, it was 84%. So we basically mild is plus minus, but I think by and large we do good for moderate, but very good for severe. And
With IVUS.
Okay.
put the IVUS on the center screen, please.
Okay.
Okay, start work is coming. It's a distal part of the D2. Yeah, here's a good landing zone. Kind of a micro bridge, but there's no calcium. Some blanch. It's coming back. Some fibrous block. Yeah, 1 quadrant calcium. Kind of small, like
Yeah, there was no
attenuated
calcium in the
block.
bag.
Yeah, there is some but less than 9, right?
Yeah,
There
not
are
so much calcium.
You got it.
Yeah. Could you flash a little bit? Sorry,
Flash.
Michael Baba. Okay, thank you. Yeah,
Okay,
room is
that's
getting
LED.
bigger. There's some vein outside.
Question is, you put a 16 stent or
Yeah,
a
now
10?
come to the main LED. Yeah, here's an audio protruding inside.
Wow.
Yeah, and a small hematoma. Yeah, eccentric
This
plaque.
section.
It's a dissected part here.
Yep.
Yeah,
Yes.
here's a
Quite a
luminous
bit of
graph.
dissection. Yes.
Yeah.
Yeah.
Now this is a good normal healthy part. Okay, eccentric plaque. Yeah, big vessel.
Yeah, it's a big vessel. One
Yeah.
bed.
Yeah, now
So
come
that's
to
a
maybe
second base.
bifurcation.
And
Yeah.
this
Yeah.
is a rectomy. And that's a nice, rotability effect. We just pass.
Yeah. Now come to the
Okay.
aorta. Yeah, I will stop.
But actually, calcium was not too bad.
Yeah. I mean, I would say that I have
I
to
think
correct
some-
myself now.
Yeah, some
That my
insurers-
prediction, I was right on the diagonal, but I totally lost in the LAD. The LAD and left main by angiography is not a circle.
Yeah.
I mean, on the IVUS.
Yeah.
While angiographically,
Yeah.
I thought will be severe. This probably will be in the low 1 to 2 score or so from the IVUS point of view.
You want?
Yeah, well, Dr. Sharma, the most severe part is just before the diag. There is a protruding calcified nodule.
Yeah,
And
calcium
maybe-
nodule is there. Yeah.
Yeah, we did a lot, or maybe we did
Yeah.
not.
The rota and balloon has been done. Yeah. Tell us what you want to do. Yeah?
Promos,
But I think the
Sorry,
most of the calcium is less than
Boston
180.
Scientific.
Promos, why not?
Huh?
Promus?
Yeah,
And
do
also
promise.
you have the nice
Okay,
dissection.
2516 Promus
Yeah.
bag.
Yes, I think you are ready to stent.
No, synergy.
Hmm?
They want
Sure.
to prefer synergy.
Oh, synergy. Synergy.
What was the question?
क्या बोलती पता नहीं.
I know. Yeah, so
Can you show us the ostium of diagonal on IVUS?
yeah, show the ostium of the diagonal on
Sure.
IVUS.
So this is the diagonal lesion. Go to the proximal.
Yeah, right there, right there. Right.
Yeah, 1 second. So now this is the bifurcation.
Yes,
So
yes,
this is
come
the
back.
osteodiagonal.
But we have to cover from the distal proximal LAD into the diagonal anyway,
Sure.
because we cannot leave that angle. So even if there was no disease in the proximal, we put a one separate stent in the diagonal further, but then we put a stent from, how do you want to do it?
We'll
Leave.
stop at the ostium of the. We are not.
Okay. Then you need longer one. Where is the stent?
2516 synergy in the diagonal.
Yep.
Then we will put a stent like this in the LAD. That's it. We are not
And-
getting into the ostium of the
Okay.
LAD because
So-
the size is a big mismatch.
Okay.
True.
And then we can do the ostium of the diagonal is not involved, correct?
Yes.
Yeah. So we
Not
are doing
involved.
just a focal stenting, right?
Yeah, that's
Yes.
right.
Focal stenting of the diag, even angiographically, I
Right.
think it looks the same.
Yeah.
We are going to put a 16 stent there, and then we will wire the circ now after this. Cut the ostium.
And 3.5, 32, LAD to left main.
Okay.
Okay, so we are putting this 2.5, 16 synergy going into the diagonal now. Synergy XD. Yep.
Further modification of plaque in the LED proximal and the distal left main, we can use a Wolverine 3.5.
Okay,
Before
so
putting up-
I think that probably will be a good choice. I would agree with that.
Wolverine for what?
3.5 to the distal left main. Okay, let's
Left main
do this one.
approximately.
And then we have to go into the other view and we'll see.
Some die.
Good.
Okay, good. Go.
It looks good.
Yeah.
2.5. Go.
Now, what is the experience with the orbital? I know we started orbital in India and they're being used. What has been the subsequent experience? I know
2.5
Sanjeev has
high
done some
pressure.
cases also.
2.5
And
high
what of
pressure.
Dhiman and Ankush?
Yeah, Orbital has just arrived in Kolkata
Yeah.
about a month back,
Ah.
and a few cases have been done. One thing is that the bar size is constant, 1.25.
Yep.
But it's good. It's 360-degree cutting, and the results are also good. Fortunately, none of the patient had any complications.
Dilate
Now,
middle, same
Shalim, I have a
0.5.
question. How do you choose that, how do you choose that whether you go to do this rota or this orbital?
Yeah, so I know the part of that which we published, but that was before the days of IVL. But otherwise, by and large, I think both can be used interchangeably. But one thing we know that rota definitely cause slightly higher slow flow. So in a hemodynamic compromised patient, probably orbital may be a better choice. But where you don't use orbital is your angulated lesion and aortosteal. So clearly, because the burr will have no control and will have multiple vertical movement. So in that situation, you basically want to avoid. And then, of course, we used to say if you're using a large 2.25 burr, but that should not be used now anyway, because there is no reason for us to go beyond 2.0 burr. Because if you need to have a second device in a large vessel, now you use a IVL.
Yeah.
Dr. Annapurna, the ostium of the diagonal and the distal part of the LAD, there looks like a flap there. At least angiographically, it looks like that.
Yeah, at
We
distal
get some,
part, exactly at the
ballooning.
distal part, yeah. Yeah, there was at distal, before the diagonal, there is a flap, but you'll cover that with the stent.
We're going to cover that with the stent, yes. I think the goal will be that we will take care LAD up to the ostium diag.
Yeah.
So we'll do 3.5. But
We go
before
to
that,
caudal?
let's wire caudal,
Yeah.
right?
No,
Yeah, we
no.
take care of the
Will you
circ.
stent into the diagonal or you will not stent into the diagonal?
Well, that is part of
we
the
are not
discussion,
stenting
yeah.
into the diagonal. We will stay before. Let me go back.
Yeah. Yeah.
You see that?
Here it looks
Right
like
now
a
you are
dissected
looking,
area.
no, dissected, it's a wire bias.
Yeah.
Wire bias
yeah,
because the
I
wire
agree.
is going from the LED into the diag. That's why it looks like that. Once we stent it, you will see it look perfect. Yeah.
And you can bring the wire into the LED at the time of
We can
deployment.
do that too.
Yeah. Okay. Let's see the.
That way we a strut may get into the diag ostium, no. So we don't want that.
Okay.
Because this has LIMA.
Yeah.
We need a
Diagonal cover.
diagonal
Okay.
to
Let's
be
take a
covered
picture.
first.
What's the plan for the circ?
Okay.
So let's talk about the circ now.
Get the fielder wire. So we're going to wire the circ.
Okay. But let's see what we need to do. Just proximal ostial or anything more.
If we should wire into the OM1, which is a moderate size vessel and has nothing, no bypass there.
Yeah. Good.
Right?
See, there is no disease in the ostium. Subsequent OM2 and branches filled very nicely by the graft, and there's no disease there. So we just try to do ostial proximal circ, which will take care of the OM1. And that was the lateral ischemia. As I said, the patient has a significant lateral ischemia, which I could not understand, mild apical ischemia. This patient has a fantastic LAD. Going to the LAD, we see many very common, I'm sure you also, that post-CABG patients have apical ischemia, perfectly working LIMA. We think maybe it's from the proximal LAD, but it remains the mystery from my point of view that why with a good working LIMA, that apical ischemia. So this patient has apical ischemia and lateral, but significant lateral and mild apical. So I think the lateral was from both proximal circ into this OM region and of course the large diagonal.
Dr. Samin, if you need to modify that calcified nodule, what is your device modification?
No, I think we had done you are a very good point. So I think part of them we had done already. Some shaving we are already done with the rotational atherectomy, and now rest probably we just do a cutting balloon. Yeah, use a 3.5 cutting balloon.
You want 3.5 cutting to the LAD?
Distal left main and LAD. That's where was right in the proximal part, where was exactly that large protruding nodule was?
So
in the mid LAD.
Yeah, so fine.
So
but I think that nodule will take
It was just before
there's a nodule, but the area is okay, like more than 4. So we can put a mid to the ostial left main.
You don't need to modify anymore. We've done enough with the balloon and rota. We will be able to crush it with the stent.
Okay, 2.5 balloon, right?
Balloon? You mean cutter will not go?
And the mid LED side is 3.5, left main 4 low, maybe 28 will cover from the mid to the ostial left main.
Oh, 3.5 cutter?
Yeah.
Wanted a 3.5 cutter?
For the left main. For the left main. We're talking about the ostial circ. Question is balloon, cutting balloon, or what else? Okay. That's the question. You have 2.5
so
balloon. I think
can we thought about after cutting balloon? Can we thought about using the DCB in the circumflex ostium?
Very good point. Very good point. So question is, as you know, absolutely. I think probably by in 2 years in America we'll be using the DCB. The DCB balloon trial just started, and for the drug-coated balloon right now for the ISR, and then get to the small vessels as once the ISR is done. So magic touch and solution drug-coated balloon, which is the Cordis Meta-Alliance. We are part of it. We did the first of sirolimus here at Mount Sinai 2 weeks ago. And this is the ideal case. Do a little balloon and drug-coated balloon ostial circ. Absolutely. But with limitation again that we don't have this. So what are you doing now?
We are doing the 2.5 cutting balloon to the ostium of the circ. So,
Wolverine. 2.5 Wolverine here.
And then we will have 3.5 to the left main, and then we'll do MiniCrush. 2.5 12 to the circ and 3.5 32 into the LAD.
Good.
Okay.
Okay. Now IVUS wise, can you give us the length?
Sure.
From the left main
to the mid landing zone.
Origin of the diagonal. I said 32. Let's see what you say.
Oh, but we don't cover to the diagonal, right? So
no.
So mid to the ostial is, I think 28 will enough to cover the lesion. So ostial left main to the mid good landing zone. Well.
By any chance, are we planning to do IVUS of circumflex as well?
Do you want?
Just to see the landing zone?
No, the point is the short proximal. We'd use a short stand there.
Okay.
Well done.
Well, I think right now, since there's not much calcium, looks good. We'll do in the end.
Yes.
After the MiniCrush. But I mean, I always say that you want to add the steps of the imaging, but knowing that if they are going to help it. So you tell me, I mean, is it going to change our strategy at this? Let's take a picture. You know what? Let's take a picture first, and then we'll decide that is it going to help us in any way.
I
That
think
will
that's
show us
how,
whether the lesion has been adequately modified or not, I think.
I think that this sac could be
And also the
worse
landing
than
zone.
2.5. So you
Yes.
should do the IVUS.
Okay.
Okay.
Do the IVUS of the circ.
Sure.
Yes.
That do we need to go to a bigger vessel or so? So lesion has
Yeah,
opened
that's
up.
the expectation, right?
Okay. So you know what? Before do the IVUS, why don't we do your 3.5 of the left main and circ?
It's already dissected.
I mean left main.
Not just stent it.
Huh?
Look at the left main.
Okay.
Already dissected with
Fine.
three.
Okay. Good. Do the IVUS of the circ then quick.
Okay. No. You want
I
to
think
take
everything is
over here?
dissected.
Yep.
Yeah.
It needs
Which is
fixing
good.
fast.
Which is good. The calcium dissection is
What I
good.
meant where-
Yeah.
Because if calcium did not dissect, means that's just over dilated and will recoil.
So you want IVUS
clock
of the
modification.
circumflex to get the vessel size?
No, more important that have we done or do we need to open a little more?
Okay.
Yeah,
I mean,
will
I
show
can
us
tell
that
you
the-
angiographically we have done well, good modification, but let's image.
Okay, we are imaging now the left main to the circumflex, just short imaging.
Sure.
So we are going to take a stent up to the OM.
Yeah, just before. Because
Before.
remember, there is a not much
12.
disease. I would say
12.
maybe 12. 2.5, 12 in the circ or 2.75. We'll look into it. And the main, they're saying 28. We thought 32, but we'll decide that also. Yeah.
Let me
Okay.
check the image.
Good.
Okay, start to work.
Image. I was on the main screen, please.
Yeah, this is just before the OM. Yeah,
Hmm.
there's a fibrous plug. Yeah, like 1 to 2 cardan calcium. Yeah, diffuse plug.
Good modification.
Yeah,
Here's
an audio.
dissection.
Here's an
Is
audio.
there a dissection?
It's a nodule.
Play.
Yeah.
Nodule, yeah, nodule
Again,
protruding
plate
inside.
again, yeah.
This is the left main.
Okay.
Yeah, sac is not super big. Yeah.
Yeah,
Yeah,
that's
true.
it. 2.5, yeah. Actually, it looks like
Yeah.
distal branches, more of a negative remodeling because OM branches are bigger than the proximal
Yeah.
circ.
Yes.
Good. Okay, let's
Yeah.
go.
Yeah,
Scientists.
it looks like
Yeah,
vessel size is 3.0,
Okay.
but there's no good landing zone. Maybe 2.5 is safer.
Yeah, I know 2.5. Yeah, I know landing zone is not there. You mean go up to the OM, right?
And
12,
actually,
I think 12 is a good length.
Yeah, 12 is good.
Yeah, 2.5, 12 to the circ, and he's saying 28. To me, angiographically, it's 32.
But he's saying 28. Keep 28. But put wire in the LED.
No, yeah.
No?
Kiski, you're saying from the aneurysm up to the left main ostium is 28?
I mean, from the mid lady, the good landing
No,
zone
no,
to
no, I'm talking up to the dag. Origin
Oh.
of the dag to the left main ostium is
Sure.
32.
diag to the osteo is like actually 38 by IVUS. Osteo diag to the osteo left main is a 38 by IVUS.
38.
Then I think 32 will be good, no?
Yeah, 32.
Yeah, good. Okay, good.
We go with our eye thing rather than the eye.
So now question is, we have dissection, although we have 3.5 Wolverine ready.
You want?
Should you do any modification with that dissection? I will be a little worried about having perforation now. It's a good size dissection, type B to C, and the lesion has opened up. There was a nodule, but we have shaved the nodule partly. So let's just go with the stent strategy and with a MiniCrush, and then we'll dilate. So let's get a 3.532. Yeah.
Dr. Samin, why have we chosen MiniCrush as a two-stent strategy here?
Yeah. So again, I mean,
It's okay. What are the other strategy? We understand you can do
DK.
drug
DK crush.
coated. Oh, the
no, DK crush. Yeah,
No,
yeah,
I
DK
wanted
crush.
to ask them what's the other strategy they want.
No, but no. Initial was that just put a drug coated, but which is we don't have the choice. So now just because of the tight lesion, what else can you do? So one will be using the MiniCrush, drug or DK crush, or some people will do a culotte. I think more people in Europe culotte. That's what they did in EBC 1 bifurcation. So key is that yes, we always have favored the MiniCrush over DK crush just because of the less steps. And people say, well, one of the biggest advantage of the DK crush is that ability to wire the side branch and your kissing balloon inflation is much easier. So that is one theoretical, but we have not noticed it. And that is what we always have been propagated, I would say.
Okay. No,
Yeah, let's see them now. First, we see what side lengthwise we cover or not.
Any other technique we are talking about or left main DK? Okay, good.
You want to go to epicranial to see
I
exactly?
think we're good here. Epicranial when I'm doing the left main. Now let's place a circ. Yeah.
Let's take a cine. So we actually are 800 plus cases. Sorry, not 1800 plus cases. 1800. Our fellow working on looking at all the techniques from angiographic point of view, the time taken, side branch access of the DK crush. We basically do 75% MiniCrush, DK crush in about 15%, and the reverse or the step crush or tap in about 5-8% of left mains.
No, we are talking everything.
Huh? Yeah.
Non-left main.
Yeah, I know. So the whole biggest question will be the DK crush for the left main. That's where the whole concern is, everyone's and so. And the trial, I mean, so much so you believe that. So when they did our EBC1, they didn't even consider the DK crush as the default strategy in the two-stent group. There did majority they did with a culotte. So I think it's a good technique, but best is you do what you do the best. And we do MiniCrush. Majority of our cases are done with a MiniCrush. Good. You want to put a wire in the LED or just keep it there?
What LED? No.
Okay.
That's a LIMA.
So this is a very important step. Make sure you cover the ostium of the left main. And the question is, if you don't want to cover the diagonal, that's a different story. Although you can go to cover the diagonal also. Good.
Good.
Yeah.
I think stent has gone up to the diagonal.
Yeah, it has gone up to the diagonal ostium.
Yeah. So if it has gone into,
I'm pulling back a little bit. Now you have to come up to the ostium a little bit of the left main also, and this is what we want actually. Some die.
Yeah.
And remember this, the synergy. Stent is inside the dot.
Yeah.
Yes.
Okay, die. You don't see it well.
I think 28 was the better size.
No.
He said 38.
It was 38 by.
Yeah.
I mean,
28
would have brought you to the body of the left main.
Yeah, that would have been a little trouble. Yeah.
28 will miss.
Good. Yeah, this is the 32, and let's take a picture and see where we are. Yeah.
Some die if the ostium there.
Because this barely covering the ostium. You want to
Barely
bring 1
covering the
millimeter?
ostium of the left main also.
Yeah.
Now die there.
Good.
So that's a very bad, right?
Yeah, that's fine.
Okay,
Yeah.
this may be okay. Some die there.
If you can
Yes,
just keep
now we are good.
another set.
Yeah.
Yeah.
So basically now we are taken out of the wire from the circumflex
Some die.
and we are deploying the
Okay.
stent in the left main LED up to the diagonal ostium,
Yes.
but not going into the diagonal.
Okay.
Yeah, that's good.
Yeah, you want to just okay?
just go up.
Fluoro, go up,
Yeah,
go
go
up. Now looks good.
Go.
Okay, down. Go up again. Do you have a left main MiniCrush video?
Video.
Yeah, play.
And
Just to avoid the ostium of this synergy stent with the help of the guiding, if you can just keep the wire which has already been there in the primary curve of the guiding catheter, if you can keep as a sample wire, will it prevent the damage to the ostium of the stent at the left main?
I mean, the key is that multiple advancement of the guide can cause vertical distortion, longitudinal deformity in any one of them. But our goal will be that we, and that's what we always teach also, that when you are advancing the guide in the left main, and where you put an ostial stent, make sure you advance that on the balloon. Because without
Correct.
balloon, take a picture if you have it.
Okay, okay.
Yeah,
No,
yeah,
what happened is you are stuck.
yeah,
I
that's
think.
fine. Yeah, just take a picture.
Go.
You need a little
Nice, it's
better,
like
yeah.
a-
But looks quite good. Key is and that's why otherwise infolding of the stent at the ostium will happen. And actually, we have had a few cases done that gave the trouble to few rare cases. But yeah, key is that keep the guide, don't go back and forth. And if you had to advance the guide, you do it on basically on the balloon. So now we need to do IVUS, right? What is the plan now?
We have to kiss,
Yeah.
then IVUS. That's
Yeah, let's do the kiss. You go to caudal again.
You have to recross into the circle quickly.
The circ wire.
More important,
Hmm.
the sticking
Good.
brought the other wire out.
Left main side is 4-0.
Yeah. We can take a 408 also
Yeah,
or 12. Yeah, 8 is good. Yeah, we have that.
go to the caudal, right?
Yeah, we don't have the
Wait,
pot
one
balloon in
second.
America yet. So we have been using that pot balloon. It looks like very impressive. We saw that in India live. People using that pot balloon.
It has got almost nil shoulder. It's a fantastic balloon.
Yeah.
6 mm.
And
From
6
Lima.
mm. That's another good one. Yeah.
Yeah.
We have 2.5 balloon ready. Okay. We are recrossing the fielder wire into the circ.
Dr. Samin, why are we
This
not
guy
using
moves,
pot first before recrossing?
That's a very good point. So some people will use the pot first, then recrossing. So some will use do it, kissing, then pot. So I think this is a various strategy. What our threshold is that if you're a little difficult in advancing the wire in the side branch,
Pot.
then you do the pot.
Foro,
yeah.
Okay, let's take a picture in the caudal, right?
Yeah,
We
yeah,
never took it.
yeah.
Wait 1 second, wait 1 second. 408, okay, go.
Good. Get 2.5 balloon first. Yeah, you have 2.5 balloon. Huh?
Circ flow has gone down.
Which one?
Left one
Circle.
requires.
No, it is
Yeah.
open. This is okay. Yeah. Yeah. Let's see. Go 2.5 balloon, which we used earlier.
It's just 100% not going to go, not 99. Here,
The question is, will that use balloon? Let's try. Let's try now. You're good. The other one, no? Which one?
okay. No, I know, then,
Yeah. Let's see. Go negative on the balloon. Otherwise, use a compliant balloon 2.5 or what?
should I do pot first?
Pot first. Okay, good. So let's do the pot first. 408. Pot first.
Circ flow.
Yeah. No, but circ has little decreased flow. I think part of that lot of plaque shift there.
From where?
We just have to, there's so much
I
calcium.
think I think
Yeah.
That's not calcium.
I think there is hematoma distally
Yep.
in the circumflex.
Yes, that is the reason there is a reduction in the flow.
Flow. Exactly. Okay.
Most of the operator, prefer pot before wiring because your wire may go beneath the stand and it will increase the, that side branch wiring will be easy and better. This is what we, usually follow at our center. They always do a pot before recrossing the side branch.
Recross.
No, and I think that's a good strategy. But at the same, so question is if those who don't want to do it, because that will be a multiple pot, repot. And so some people, key is that you go into the distal vessel and then pull back. So let's say if you go into the left main, to the LED and then pull back and then go to the circ. But yes, doing the pot at this level is completely fine. Yeah.
Okay, get us the 2.5,
But leave this balloon, no?
2.5 will not
Okay.
go. You mean why? To kiss?
Good. Take it out. Okay, take it out and let's go because we have to show you the IVUS aid. Do you want to show that IVUS?
Yeah, yes, good.
Both IVUS and IVUS aid both.
Quick.
Yeah, let's get a 2.5 balloon, which we have used before we're going into the new one. It's a used one. Get a 2.5 12 compliant. Yeah.
Get us a pink
Yeah,
balloon ready
yeah,
also.
Yeah. Okay. So I can tell you we go negative, real negative, and then it should be able to go. Because left main, yes, in any diagonal will give little trouble. Using the used balloon, yes.
Do we have anything for the LED? No, right? We have to use the same 4.0, you're saying?
We have,
No,
we
don't
have
open.
3.
Use the same, no?
Yeah.
Or post it.
Okay.
You understand, SS? Never have a trouble with this balloon.
Okay, what we do is we're going to decrease the profile. 1 second, bring the balloon back in the guide. 1 second. We do a profile reduction. And now go. No. Okay.
Angle also is a trouble.
So you need a compliant?
Yes.
Yeah, different balloon. Okay. Yeah, same.
Get us a pink balloon.
So same thing, you
What
don't
size
want
you
to.
have? 2.5. 2.5? 2.12 pinky.
Yep. So key is that don't try to push too much guide. You can cause the damage of the ostial stent of the left main. And we're going with a 2 balloon followed by, then we'll do a 2.5. So this is some
Euphoria. It's
Yeah.
Medtronic.
Medtronic Euphora. All
So
kinds
Dr.
of balloon has been used.
frequently you use
It's an
anchor
NC balloon or a compliant balloon or non-compliant?
It's a compliant balloon.
compliant.
Yeah.
It's a compliant.
That was a used non-compliant balloon which we were having
Oh,
trouble.
that was the
which is
reason
always
it
the
was
case.
not. Yeah.
Yeah,
Yeah,
yeah.
yeah.
Correct.
But I think
Which
it
you always
should
know
go.
is trouble.
And despite-
I know.
And that we did not have even with the after the pot. Yeah, sorry, there was some question about, yeah. Good.
So yeah,
Good. Very nice.
Good.
It went.
so how frequently you use that anchoring balloon for crossing the?
Yeah.
No,
we-
if now this would not have gone,
Rupture.
we would have done an anchoring balloon. If it would not have gone, then I would have gone with anchoring
Good.
balloon.
Good.
Okay, get a 2.5 then, right?
Yeah. We go back to the 2.5 same. And we have the trio for the LED 3 point. Yeah.
Trio is good enough, right?
Trio is good. Good. Yeah, good. That's good.
Get us that trio, yeah, back.
Let's get a 2.5 first. Yeah. Good. So then we are ready to show. So now question always comes that you have done the kissing, then do you do the report? We should take the vote. And any of the question from our the audience, if they put it in the chat, if any extra questions needed, we
Get
can
the LED
answer.
balloon. Yeah. Prepare it again.
There's a question from Dr. Bilal
Yes.
that why there is no view for deployment of stent in ostial left main in elevocranial view. So this was being
yes.
asked.
Yeah, very good point.
This was
So
being
question is, you
around-
need a cranial view, whether aleocranial or the areocranial.
LAO, straight, RAO, and in this case, we still could not see it. We came a little bit AP. We decreased the angle. That's
Yeah.
it. But has to be in the cranial view.
Cranial.
Sometimes could be straight AP, rarely AP, but not in the caudal. Caudal is foreshortened. Ostium is foreshortened. You don't see it.
So
Distal, yes, distal left main. You want to do anything, caudal is okay.
yeah, so aleocranial, we didn't use in this particular case because, you know, my personal experience with the aleocranial had been that you still put little extra stent in the aorta.
Circ.
Yeah.
Go
So
to
I
pressure.
so I basically go with the areocranial. Cranial has to be go.
No, wait. Individual, down.
Yeah.
You go.
What is the size of LED balloon?
Same
Three.
3.5.
3.5.
Yeah.
Good.
3.5.
And when
So
we
both.
we individually go up to 18,
Yeah,
and
go.
now both will go up to like 10, 12.
10, 12.
Yeah.
And what I can do is that pot, you
After
bring
this,
back
IVUS.
both of them to the ostium. No, dilate both of them. Now this is your modified pot balloon.
Get me the IVUS. Yeah.
Okay. All right. Good. We do the IVUS and then want to give a little nitro. Let's give a little nitro and verapamil.
We'll take a picture first and
No,
then
little nitro. We have to rehabilitate the vessel. Vessels have been damaged quite a bit. But definitely no dampening.
So you don't recommend repot here.
Yeah,
No.
so report. I mean, let's see. If you got a good,
Size.
we are doing the IVUS. If there's any question, they say, but you'll make it a little more vertical, the circular, like the elongated. We'll see. Now you're doing imaging. Go. Good.
I think it's beautiful.
Yeah. Yep. Now
It looks
fine.
very
Good.
nice.
Go quick. Because you have to talk
And you
about
talk
your
about
things.
it
Remember,
looks-
time is going. Yeah. So we are doing in the LED. And then, of course, you'll see that very nicely it has come up to the ostium, the stent. And why I say that? Because you're dampening. Now, you show the hemodynamics also. that no longer ventricularization. Although we give a little nitro pressure slightly downwards, but no ventricularization. Yeah.
Let him start, okay? You're ready to IVUS?
Sure.
You're in
Yeah, yeah.
Bring
LV?
the IVUS to the main screen, please. Yeah. Good.
So I
So,
went to the ostium of the diag, okay?
Yeah.
Yeah.
Good. Start.
So the guide is out, right? So
Yes.
yeah, start
Oh,
full back. It's coming. It's a native. Normal vessel. It's coming. Some plaque. Wow. Section.
Flush.
Still native. Yeah, here's the
Good.
nodule
You
part.
see the stent now?
Yeah, this is a distal edge. Yeah, looks good. Yeah, good landing zone.
Yeah,
Yeah,
it
and
does.
well expanded.
See,
Yeah.
perfect
Nice approach.
landing zone.
Yeah.
Exactly what we
Yeah,
wanted.
can
Yes.
see the outside eccentric costume, but area looks good.
Yeah.
And see the nodule. When you come to the level of the nodule, you see that that's been.
Yeah, now come to the left main bifurcation. This is the left main. Yep.
Do you see
In
the
elliptical shape, but it
double
looks
layer
good.
of the circ?
Yeah. Now stick to the left main, so it's
And
all
then
covered.
head out of the
yeah,
stent.
yeah. Just
Yeah.
one strut, one strut.
I think
Good.
very
Yep.
good approach.
Yeah. So that's it. See, visually we said 32.
This was the
That's
nodule.
exactly.
Take the wires out.
Yeah.
No, I
Okay,
have to
like
do the
perfect
circ.
landing zone, I think.
No, no,
Circuit
no,
good?
no need to IVUS inside.
Okay.
We have to just talk about that. This is
Huh?
all done. Looks good. Huh?
Looks very nice.
Yeah.
Yeah,
With good opposition and good area
Yeah.
achieved.
Good.
true.
Yeah.
Okay.
So with
That's
that note, I
RC.
want to, we wanted to talk
That
about
was
the
gone.
new IVUS. Oh, you still bradycardia?
Yeah.
The same thing did.
Osteo left
Why
main area
did
is
you
like
take
No, I thought
seven.
we're done. Okay, we have to put a pacemaker again. Go to the pacemaker. Give a little atropine. Case done. Huh? I'm sorry, what? So this patient still requires, you know, same thing happened last time. I thought you didn't need it, but patient still need the pacemaker. Will put it back.
Left main
No.
area is like 9.6.
Give a little atropine.
Good, but this is okay. It's coming back. Show the
Not even that because the RCA now.
show the hemodynamics. Yeah, so it's a little bit of issue, but nothing. I don't know whether you need to put a pacemaker. You can just wait it with
Yeah,
atropine.
wait. Yeah.
Yeah,
Okay.
don't do anything. No, it will come back with little atropine. So patient just,
Everything out.
but that okay. So now with that note, we saw the last picture here and show the, we wanted to just show, Anu wanted to about IVUS cathode. You're done. You finished what need to be done. Take a
Okay,
picture.
but
So,
show that. Any questions
Yeah.
before we show you the new app that we released?
yeah.
So these are the various apps that we have from our website, which is where they are free to download. You can go to cardiologyapps.com. The new one that we released 2 weeks ago was related to IVUS, called IVUS Aid. So the key features you will see as soon as you open the app is principles of IVUS, how it works, how to do image interpretation with annotations. Then we have over 21 case reviews and we keep updating them. About 50 quizzes with the test, with the explanation.
Good.
And
Good.
of
Put
course,
the pacemaker.
recommended reading with up-to-date any publications on the IVUS. So when you do image
Take the guide
interpretation,
out.
you can see annotation and no annotation. So if you don't know what is the image showing, then we have annotated to say what they mean. And even for lesion morphology, you have pullback as well as still images that you can see in these cases. Yes. Then all the case, one by all the cases that you have done. One thing about that we do, our apps and the cases that we show, they're all from here, Mount Sinai, all the live cases or other cases that you have done, you will see them. Then we have case examples. If you see each case presentation, that was just IVUS cases, but this is with angiogram. You can see the angiogram plus IVUS, what has been done also. This is on the web app.
Just
Also,
continue
the
hemodynamic
quiz
monitoring a little
is
bit more.
nicely done. They will present IVUS. We will ask questions, and then of course there are explanation for each of those questions when you pick that, so you can take it. So if you do 1 or 2 questions, you go back, then when you come back, you can start with question number 3 where you stopped. Yeah. So there are more apps coming out shortly. The device aid will be out in the next month or so, and we are going to update the calcificate because our calcificate came out few years ago before IVL was there. We are going to do a second version with inclusion of IVL. Right now, remember the hot topic is calcium nodule. Management of calcium nodule will be included in that app.
Okay, so any other question
So
about
one thing
apps?
is,
Yeah.
no, sir, I just wanted to give, I must congratulate you all of Mount Sinai people because this is one of the best apps what we have seen in last few days. Like I'm using this IVUS head in last, like it was being released, I think 1 or 2 weeks back only.
Yeah.
Yes.
We are using Bifurcation since long, but IVUS head is really good. And you have started with the distal left main cases, scared cases. There are so many quizzes, and the beauty is that you have already included almost like an atlas. Like if I want to see the artifacts, you have given the artifacts. If I want to see the ring down effects or a side lobe artifacts or anything in IVUS, it has been there. So I strongly recommend that we must download this app and use it in all our selected cases.
Beautiful, beautiful.
Thank you.
Okay,
Thank
so
you so
with
much
that
for
note,
the-
we are exactly on time, and I thank all our panelists,
Yeah,
moderators,
beautiful
and so.
guest.
Yep. And I will join you shortly. And I think, Jay, you carry on from here, inviting Dr. Akiko Mehra for the IVUS guided left main PCI. So thank you very much.
Thank you. Thank you, sir.